So we're going to go through the idea of trying to create shoulder abduction or abduction of the arm with respect to the body, using the concepts of explicit teaching or explicit visualization, explicit learning, as we are going to continue to do. Sometimes you can think about this, sometimes you can't figure it out, so if somebody shows you the process at least, you can attempt to apply the process to other movements. So the idea of identifying the process of the motion first is to understand what the motion is. So what we're going to have to do is just put your arm out here and just raise it straight up to as close to your ear as it can get. So shoulder abduction, movement away from the midline of the body, primarily in the coronal plane. Okay, so we'll come back down here. So if you see that movement, right, you see that the arm is going to be essentially beside the body and go up almost like if I was doing with both arms, like jumping jacks or like making a snow angel on the ground. It's just for visualization purposes, if that's helpful to you as an individual. So what we do is if we want to create shoulder abduction, I can, in a seated position, lift that for the patient. Right? Another thing that I can do is come up to here, support. Now what I want you to do is I want you to lean that way. Now as he leans, I start to get some more gain. Right? So the shoulder gets closer to the ear. Although his head has come off midline, shoulder starts to get closer to the ear. If he leans more and more, right, the angle of the shoulder, so if you look in here, the angle of the shoulder changes, I get more abduction. So just say this is as high as the person can actively raise, then we can start to work into barrier and into bind by doing that. That's a way. We're looking at the idea of relational motion at that point. So I want the humerus to move away from the body in an arc in the coronal plane, and I want it to move towards the ear. Right, so now we take a look at this process and putting it into different positions. So here's the explicit portion, and we actually show you in different positions. So we're going to have you lay on your side facing towards that. Okay, shin back to. Okay, so patient positioning. The idea that the table makes stable. Less stable means I need to make the patient more stable. So the patient's on his side, he's not as stable. We talked about this previously. A nice setup where the hips are and knees are essentially approximating 90 degrees to keep the patient safe. They come back closer to me if I'm standing behind them because the space between us is unstable. Okay, now the anatomy that I want to work on is exposed, free to move in the plane required, and it is visible for me. So in this case, I can pick the arm up, I can support it, and I can simply walk, and I can create that shoulder or humeral or arm abduction. I can take it away from the side of the body, so my key is I put it to the side of the body, right, in the mid-axillary line, and I move it in an arc in the coronal plane towards. So we've got that. Now in this case, I can't absolutely lean the patient's body towards the arm. I have to take the patient's arm towards his head. What I can do though, again, this is the explicit process. What we're going to have you do is sneak this shoulder forwards. Okay, now what you actually lay on your back for a moment. Right, and see the point I'm going to make here is that there's a process. So briefly I thought that there was something that I could do when the patient was in lateral, but it wasn't going to work. So now what I want you to do is you're going to take this arm, you're going to put it up beside your ear, right? And now what I want you to do is roll onto your side over top of that arm. Right, and let your knees bend, and then put your head on top. Right, so this is essentially a sleeping position. So for some people, they enjoy sleeping like this. So if a patient won't actively, if there's a reason that you're having trouble actively doing this, then you can essentially have the patient in a position like this. So on your back. Okay, so this is the process. I've tried to figure out a way when the patient was already on the side to get him to do it. The instructions didn't come to me in my mind. So put your shoulder up by your ear and roll onto it. Okay, that is shoulder abduction on the downside or on the bottom side. Now what we're going to have you do is sit up for a second. We're just going to move the pillow. We're going to have you lay back on your side, and as you're doing it, put that up by your ear and lay on your arm. Okay? There you go. Not the most controlled, but the purpose is to explicitly show you the process of trying to troubleshoot on the fly. What does it look like? What does it sound like? Will you have mistakes? Yes, you will have mistakes, but you have a clear-cut goal. Right? In lateral recumbent, can I create shoulder abduction with respect to the body on the top side and the bottom side? The answer is yes, that I can. So we'll have you on your back again, flatten the pillow out. Now in this case, the most accessible method to do this is to simply, to create shoulder abduction, the arm is already at the side. I come over and I can simply walk up. I've created my shoulder abduction. Okay? I can put a fixed point in wherever I need to work on whatever tissues I need that are necessary, that are required. Now the question becomes, can we do this effectively and prone? Okay, so we're going to lay on your stomach. Now, the challenge is, depending on the size of the table that you're using, the position of the patient, the size of the patient, there's a lot of different things. So I can lift the arm up and slide along the table. We've got shoulder abduction, so it can be done. The challenge is, in some situations, you may not get as much shoulder extension or shoulder flexion, in that case, shoulder flexion, as you may want, just because of the position. You just may not be able to get it because they're on their front. You can do something like this. You can also, another way to do this, and we'll do it with this arm, what I want you to do is bring this up so that your arm comes up and you rest your head on your forearm. Okay, there you go. We've got our shoulder abduction again, and the patient's a little bit more comfortable. Right, it comes up a little higher because they can get the elbow to come further by sliding the forearm across their body or underneath their head. So we've got another way to do that. Now we can go ahead and we can start to add in other methods. I can pull a little bit more, I can palpate here. These are the ways that you go about creating these methods. You consider your patient positioning. What is available? What plane do I need to work in? In this case, we want to work in the coronal plane. What should I use as a key as to where to start the arm? Beside the body, in the mid-axillary line. And then I bring it up in the coronal plane. I can think of, again, making a snow angel, doing jumping jacks, whatever I want to think about to create that motion. But what I want to do is first understand what the motion is, what the relationship is. The arm moves in the coronal plane from the side of the body towards the ear. Okay, so shoulder abduction, arm abduction, whatever you want to term it, whatever is most appropriate for you. But I understand that this is the motion, this is the relationship. The arm goes from here to here. Then I want to go about trying to create it in all positions. I may not come up with the most effective way immediately, but I will come up with a way. After which, so there's explicit external frames of references. I understand what the motion should be. I know what I'm looking for, and then I can go about trying to create it, making mistakes along the way. And from those mistakes, I can then refine my process. So there's also implicit learning with that. But the implicit learning is applied around the explicit target. I know exactly what I want to do. So again, just the demonstration in action of that process. You can take that and apply it to any other motion, remembering your frames of references. Something such as hip internal rotation, which we covered previously, is a little bit more challenging because depending on the position, the patient may be in more hip flexion, or they may be in essentially an anatomical hip position or a more neutral hip position. With shoulder abduction, it's not as complicated. But again, you take that process, you understand the motion, and then you create that in as many positions as is reasonably possible. And in the more challenging ones, you can still keep the relationship in mind.